but also our allied health professionals, the speech and language therapists, the dietetics, our orthodontic teams. But I did forget to mention one person that is absolutely essential that the carer provide, not necessarily in the decision for treatment or treatment options or indeed investigations, but the follow-up care, and that's the psychologists. I found that they've become fundamental to the care I provide, at least in the long term, and I'm going to discuss their role today. This is a quote that you might have heard from other places, Friedrich Nietzsche. That which does not kill us makes us stronger. And that's something that's quite important to this. Any trauma we have a process of growing through it, and it's called post-traumatic growth. We identify the problem, we rationalize it, and we make ways to work through it. This works fine unless you have post-traumatic stress disorder. You simply can't break it. So, like you, I know what trauma is. We see that all the time. People in armies, they come, they see horrendous things. People in floods or national disasters. Car accidents. I was running on the roads of Larissa today, and I think I probably caused one or two of those as well. I know what stress is. All of us who sat exams know how problematic it can be, and the responses to the activities that we do. Moving house is another big problem that we can assess stress with. But also bringing up these guys is also a stress that adds to my life. I've heard of post-traumatic stress, and I know it exists, but I've heard about it in battlefields. Particularly in the UK, we heard about Gulf War syndrome. Vietnam was something that the Americans talk about. But it's far more common than we think. I know that our patients, not only from the treatment, but also from the diagnosis, suffer with trauma. I tell patients that their life's going to change. I explain to them, I'm sure you do as well, that things are going to be different when I've done this. I know from the research that's there and the evidence of the patients that I see that mental health is a big problem in our communities. 20% of people in everyday life suffer with a mental health issue, whereas 30% of those who come to our clinics do. Now that could be what we've done to them or the diagnosis that they've had, but socioeconomically, they may be more likely to anyway. I know that patients worry about it. This is a questionnaire used to assess the problems perceived by patients following treatment. And as you can see, psychological and emotional and spiritual well-being is actually scores higher than many of the physical, functional problems that we worry about. But even though I know it's there, and patients do worry about it, I accept what they tell me. And I say, how are you doing generally? Good, fine, okay. I know that these mean very different things to very different people. But why? Why, if I know that this is a big problem and that people are very variable in how they respond to it, why do I just accept that as a read? I wouldn't do it with swallowing problems or indeed pain or new symptoms. I would explore those. Well, I work in a big hospital. This is the University Hospital of Wales. It probably doesn't have necessarily the same volume of patients going through it as Larissa, but it has a catchment locally of about 600,000 people. And there's a tertiary referral centre to a larger area, although some of my colleagues, Mr. Exarchos, might complain about that. So I see lots and lots of patients. And that makes me have clinic rooms that are very, very full. So I have very little time with each patient to discuss not only the things that we're worried about, disease recurrence, functional morbidity that I know lots about, will assess and can actually treat personally. So I tend to skip unfamiliar ground, or at least I used to skip unfamiliar ground because it was too awkward. Did I really know the pathways? And did I really know what to do with them? So why have I changed? Why have I decided actually I've come from where I was to where I am now? What was the purpose of that change? Well, over the last few years, I've had a few problems with patients. I had 2 suicides within my patient follow-up list. They were disease-free, they were leading relatively happy lives. No evidence of depression or significant mental illness. I had a growing awareness that patients although they weren't lying, weren't necessarily expressing what they were concerned about when they talked to me. They were fine when they were not. And that's part of a collusion between us and our patients in the fact that we both want to tell people that they're fine. And actually, talking to psychologists about what we were missing and why we were less able to detect what was important to them. And going through all of this, knowing what stress is, knowing what our patients have, and talking through the problems that I had and the psychologist, I realized that something I was missing was post-traumatic stress in my patient group. So I decided to change that. So I've just put this slide in as that was sort of the overview of why I'm here. This is more about the point about what I've done from now. So what is post-traumatic stress? Well, it's a disorder that people may develop in response to a traumatic event. There's a list of traumatic events there, severe accidents, disasters, or military actions, and I've discussed those, what they might be before. But actually, we should also have a diagnosis of cancer and its treatment. This is a gentleman who had a glossolaryngectomy under our care. He suffers with post-traumatic stress. People who have to go radiotherapy undergo stress. And those having chemotherapy will tell you it's the worst experience of their existence. Not necessarily for the treatment, but what it does to them after. Post-traumatic stress is normal. I've already alluded to that. You can see what happened, us getting over it, to post-traumatic growth. Being strong enough so it doesn't kill you, it makes you stronger. That's here. But people with post-traumatic stress get stuck in this middle bit, worrying about who they are in the world, the issues that they have, going back to the problems that have troubled them, the diagnosis, how that went, what they've gone through with the treatments. And that has a major effect on their cognitive and social well-being. They can't grow beyond it. There are criteria for diagnosing it, and I suspect you might see patients that you have that express these. First of all, I guess for diagnosing it, you have to be exposed to a traumatic event. Well, they've certainly had that. The distressing re-experience of symptoms. They talk about the problems that they had going through treatment. They try not to remember it in their day-to-day life. When you go through the symptomatology, again, I talked about reliving the moment. Alertness, anxiety, and feeling on edge. Disturbed sleep, poor concentration. Some actually become quite reckless, take up hang gliding. They avoid talking about things beyond what you actually think you're required to hear. They don't like to talk about it at home. They don't often join groups. They don't often talk about their feelings. And when they do talk about them, there is a bit of self-blame. It was my fault I had this. I'm bad. I've deserved what's happened to me. And often they do feel alone without anyone to talk to because no one can relive their experiences with them. So, I've already said it's a normal event. Almost everyone who goes through our treatment gets this. But as you see, most of the time, within the first few months, it settles down to having left. They've worked through, they've grown from the problem. But there is a group of people who do not. If you think about post-traumatic stress and how much it is in the general population, about 8% of the population will have an episode of post-traumatic stress in their life. We did a study in Cardiff, in the patient group that I've talked about, and actually about 20% suffered with at least moderately severe post-traumatic stress. Some of it actually requiring treatment. I hadn't noticed this before. So how do I identify patients who have it or the risk of having post-traumatic stress? Well, I screen it. I've already told you I'm busy, so I don't do it myself. This is Vicky, she's my head and neck nurse. And when anyone's diagnosed and after they've had treatment, she will go through this, which is a holistic needs questionnaire. It goes through every bit of concern that you might have. It talks about your physical concerns, the breathing difficulties, etc. Hot flushes, pain. It talks about practical concerns, financial problems, work-related issues. Lifestyle information, how they're doing with their social side, alcohol and smoking, and things that they might require. But actually, more importantly for this discussion, it has these two sections, emotional concerns and spiritual concerns. And it has this area here that says, generally speaking, over the week, how were you? And you can measure this. Are they getting better? Do you expect it to go down to a point where you're happy again? Or are you worse? And each patient that we see now gets this at the start of treatment, so we know where they are. They get them after treatment, and that's generally about 3 months after they've had their radiotherapy and chemotherapy completed. And we follow that stepwise for the next few months to make sure that they're taking the trends down that we expect. For those that don't, and they sign in the spiritual or emotional sections, they get a post-traumatic stress questionnaire with a formal assessment, again by someone else. Actually, the nurse hands out the first one of these, but then our coordinator runs them. This is it, the PCL5. It's an internationally recognized scoring system. It goes through each event that I've talked about and scored between nothing at all to 4 being an extreme problem that troubles them on a daily basis. We can go through minor, moderate and severe post-traumatic stress, but generally speaking, a score of 33 or above requires therapy. Everyone below that actually can just be observed. So, how do I manage people who've had post-traumatic stress? Well, again, it's a structured approach, and this is where my psychologists get in. But largely speaking, as soon as I know it's there, I talk to an expert, my psychologist. Most of the time, if it's less than 33 on the PCL5, I go for watchful waiting. I watch it through to make sure that it settles on its own. If not, we go on to more aggressive treatment, which is generally trauma-focused CBT, cognitive behavioral therapy, or it's all related things. What you don't do is tell them, start treating it yourself unless you've had appropriate training. Tell them that it's okay and it'll get better. Start other things, and certainly don't start drugs. Venlafaxine can be good for resistant cases, but it's not recommended. You want people to grow through the problems to maintain normal life. I monitor change over time. These are both the sheets I gave before, the holistic needs and the PCL5, and I'll measure them until they normalize. But if we go down the psychological route, CBT is very straightforward. It's basically getting people to accept, to take the emotional irritation of their problem out of the equation. This is lots of writing that I don't expect you to read, but in essence, one form is prolonged exposure, whereby you just get people to experience or think about the problem they've got and learn them skills to calm themselves down, slow breathing, thought processes or repetitive thoughts that calm them down in a position. So ultimately, getting through this and learning the skills where, although they still have an issue with the episode, it matters less. Cognitive processing therapy is similar. You ask people to talk through their problems, but find solutions themselves to improve their way of life. They're successful. They generally take about 12 episodes, and people will significantly reduce their scores on both the PCL5 and the holistic needs questionnaire. But it needs to be taken by someone who really knows it. There are other methods, and this is the second line therapy, eye movement desensitization reprocessing. And generally you make people think about the problem that they've got while doing other activities. And generally speaking, most of the time psychologists will use rapid eye movement between fingers. Again, what it does is it distracts them from the stress that they feel associated with the problem, and ultimately makes the problem less problematic to them. Mild cases often don't require treatment, but as I've said, severe or moderate cases, cognitive behavioral therapy really is the way to go. What's the outcome? Well, most of the time, after the traumatic event, it'll stop down to normal recovery. But some people are prolonged and some people have it forever, although we've not found someone as yet who's resistant to these problems. What are the outcomes? Well, actually, there's little in evidence because no one really talks about it. But we did a study in Cardiff that found that out of the 75 people that we looked at, as I said, a fifth of them had problems. Two-thirds of them required treatment, and no one requires treatment any further. So, at least from a very short level audit, we've improved their outcome. So, I'm coming to the end of this, and I know it's been a sort of whistle-stop tour of what I think. Our patients suffer with post-traumatic stress. Can't avoid it. In fact, we know it. It's obvious. It's a normal part of recovery, but if it's prolonged and abnormal, we need to do something about it. It's our obligation to treat it, just as the cancer is, just as improving their functional outcomes is. It's easy to assess and to diagnose. Questionnaires that I can give out, that I don't even have to give out, can identify and give us options for these patients. And the treatment options, although research is light, appear successful. And I do think it's important that failure to act harms our patients. The outcome of significant mental issues significantly informs your ability to return to work or your social status. So, be aware of this problem. You know it's there, act on it if you think it's there. But make structures so that post-traumatic stress disorder can be found, assessed, and treated without adding extra work to our already busy lives. Thank you. Any questions?
Yeah, thank you very much, David. Are any questions from the audience?
Hey.
I have a question. Congratulations for your presentation at first, but actually this was very interesting, and I realized that we all have the same problem with this group of patients. Would you suggest that each doctor should have some kind of interpersonal skill development courses for treating, or just leave it to the psychologists, because we don't have always psychologists in our teams?
I mean, I think having a basic understanding of this is absolutely essential. There's actually there's some courses online. In fact, there's a lot of free courses online that go over these issues, and I think they're worthwhile going through. I've just completed one myself. I thought it would probably be important. But I think if you think about how your clinics are, it's unlikely you're ever going to get to the point where you've got 12 sessions of time to work someone through the problems they've got. So certainly, as a mean to know what people need, yes. To put it in your practice, I'd love to say yes, but we're too busy.
Another question? I would have a question. I lived it also in Germany. It's okay if you have a structural supporting team to assist you with this quite difficult process. But I think the most colleges in Greece have the problem that we are a little bit on our own. We don't have a supporting team. So in case like that, what would be your priority in order to assist these patients without having to invest quite a lot of time that we do not have?
So it's probably a difficult one. For people who've worked in the United Kingdom, certainly Mr. Exarchos is an example, that we are so used to working in large teams. I sit with other doctors, surgeons, oncologists, and actually my choice as being the person who decides how the treatment goes is very rare. I make it as a team. But I'm working with speech and language therapists who will tell me that one treatment option is better than another given this patient, so it's very patient-centered. It's time-consuming, but so just having teams that will do this and are prepared is what I think is essential for good cancer care. If I didn't have that structure, what would I do? Well, I would find my psychology team and I would say, how would you identify what structure, if I notice someone who's got this problem, how would I get it to you? How would I record this? How can we work together to do this? And I'm sure there'll be ways. That's how I started with this. I went to see my psychology team and said, I've noticed things, what do I need? And they told me about the questionnaire. So I started using that. So what I'd say is that the teams are all there. They may not be fitted to you, but you think if 1/5 of the patients that usually have this problem or require treatment, it's certainly something that is a need out there, and they may well want to support you.
Thank you very much.
Thank you.
And
enjoy your lunch.
Όχι, το πήρατε συνείσοδο. Ναι, στον